We will now move on to our third speaker, who is Karl Golnik from Cincinnati, who will discuss neuro-ophthalmic manifestations of COVID-19. Karl?
Greetings, this is Dr. Karl Golnik. I am a neuro-ophthalmologist at the University of Cincinnati, and I'd like to thank the organizers for inviting me to give this talk on neuro-ophthalmic presentations of COVID-19. I have no financial conflicts with any of the material in this presentation. My objective is that when we're done, you should be able to describe reported neurologic and neuro-ophthalmologic associations with COVID-19. This publication from last year, Patterson et al., reviewed SARS-CoV-2 and the central nervous system and basically sort of identified 5 major categories. Now they're cheating a little bit because number 5 is miscellaneous, but as you can see, the categories they identified were encephalopathies, inflammatory central nervous system syndromes, ischemic strokes, and peripheral neurologic disorders. And then of course that miscellaneous. In a study also from 2020, now studied patients from Wuhan, it wasn't a large number, but 214 patients, and found that about a third, slightly more than that, had some form of neurologic symptoms. They found that the neurologic symptoms occurred much more commonly in patients who had severe COVID infections, and sort of vice versa. If you have neurologic symptoms, you were more likely to have severe COVID infection as well. Impaired consciousness was the most common at more than a third, and stroke occurred about 1 in every 20 patients. There are different theories about how SARS-CoV-2 affects the central nervous system, and these include viral neuroinvasion, could be transsynaptic, through the vascular endothelium, or even leukocyte migration. The most common symptoms in this Zubair et al. Publication were anosmia, ageusia, and headache. Less commonly, as in the Wuhan study, stroke, although they found impairment of consciousness wasn't quite as common, seizures, encephalopathy, and venous sinus thrombosis. Helms et al. In a New England Journal article reviewed 58 consecutive patients, the mean age of 68, and found that encephalopathy, prominent agitation and confusion, and corticospinal tract signs were the most common things. This is a chart from that publication listing in the first sort of category neurologic signs and the frequency. And you can see in their group of 58 patients, 49 or 84% had some form of symptoms that were related to the central nervous system. The brain MRIs, which is sort of the second category down, looked at in the patients who had brain MRIs, a high rate of leptomeningeal enhancement, perfusion abnormalities in every patient, and stroke in 3 of the 13 patients with MRIs. And then they also looked at the patients in this series, only 7 of whom had spinal taps. And you can see the results. Interestingly, at the very bottom of the table, all 7 had negative PCR tests for SARS-CoV-2 in the spinal fluid. Agrawal looked at cerebrovascular disease specifically and reviewed 4 studies that reported rates of cerebrovascular disease and found that if you have cerebrovascular disease, you're more likely to have severe COVID-19, which probably makes sense. In terms of neuro-ophthalmologic problems, certainly cranial nerve palsies have been reported. Some of the first reports, this one from Greer and Associates, reported 2 patients with 6 nerve palsies. The first, a 43-year-old who had a fever for a few days, cough, and then developed double vision, a mild 6 nerve palsy, and actually had a normal MRI. And then a second patient, 52-year-old with a fever, and then a week later, double vision. Interestingly, this was all done through telehealth, and I'm going to mention at the end of the talk a little bit about telehealth. And of course, that's really increased, at least in the US, increased in frequency since the pandemic. These photographs are actually video photographs of a a self-exam through on the computer, and the patient actually during that video, which I don't have, did a self cross-cover test showing esotropia. And I think you can see from the photos fairly good eye movements, except for a mild left abduction deficit present in our screenshot or photograph to the immediate right. This double vision resolved over about 14 days. The sixth nerve palsy also resolved in the first patient over less than 1 month. There have been other reports of cranial nerve palsies. This patient from Dinkin and Associates had both a third and a sixth nerve palsy, very closely associated with the SARS-CoV-2 infection. The red arrows, and you can see the mild left abduction deficit and depression deficit on the left, adduction deficit, and so on. It's mild. Interestingly, they did see prominent enhancement, and these red arrows, excuse me, are pointing out the third nerve and its course and the enhancement of the nerve. They reported a second patient who was 71 who had a sixth nerve palsy. And interestingly, this person did not have any evidence or signs of optic neuropathy, but the red arrows are pointing out in this case some enhancement of the optic nerve sheath and of the posterior tenons area. Unknown really etiology, but findings nevertheless. Interestingly, no optic nerve dysfunction, as I mentioned. There have been reports of the Miller-Fisher syndrome, the Miller-Fisher variant of Guillain-Barré. In this patient report from Gutierrez-Ortiz et al., the two patients, a 50-year-old who had anosmia, ageusia, a right internuclear ophthalmoplegia, or INO, but also a right fascicular ocular motor palsy, ataxia, areflexia, and was treated with intravenous immunoglobulin, had complete recovery over a couple of weeks. And then a second patient, a 39, with ageusia, bilateral sixth nerve palsies, areflexia, and recovered over a couple of weeks, this time treated only with acetaminophen. And there's been one report of opsoclonus myoclonus syndrome in a 57-year-old with tremors, ataxia for 10 days after upper respiratory infection symptoms, had a normal MRI. I'm going to play this video. This is not a video of that patient, but a patient with opsoclonus. And straight. I'm going to turn that sound off. And you can see that there are full eye movements, but random conjugate saccadic eye movements, so-called saccadamania, in a different patient with opsoclonus, a finding that most ophthalmologists probably don't get a chance to see, but you can see these random conjugate involuntary eye movements in a patient with opsoclonus. And then optic neuropathy has been reported. This is a 26-year-old who had a cough. A few days later, bilateral vision loss and bilateral disc swelling. You can see the disc swelling on the photos in the bottom left. The visual acuity was hand motion on the right, 2250 on the left. There was bilateral MRI nerve enhancement. You can see here on this axial image through the orbits of both optic nerves enhancing. Interestingly, the patient had MOG positivity. This is myelin oligodendrocyte glycoprotein, as well as being, of course, positive for the SARS-CoV-2 virus. Now, MOG is something that we know MOG antibodies are associated with unilateral or bilateral optic neuropathy, and they were present in this patient. So, of course, that leads to the question, well, did this patient just have MOG and SARS, or did the SARS cause the antibodies? We don't really know, of course, for sure. And field defects related to retrochiasmal lesions or abnormalities in this patient from Bandira, 68-year-old, who complained of the inability to read. And they had bilateral occipital lesions causing bilateral homonymous defects. The rest of the examination was normal. And cortical blindness. So this unfortunate gentleman, 61-year-old, bilateral, sudden, no light perception with extensive bilateral occipital strokes, unfortunately passed away on day 3 of the hospitalization. And then a second patient with a younger person, again, bilateral light perception vision from bilateral occipital strokes. And I thought I would just mention this, that this is a survey that was done and published in the Journal of Neuro-Ophthalmology by Moss and Associates, looking at neuro-ophthalmology and telehealth. So telehealth, at least in the US, has really had a big increase with trying to see patients via the phone or video. You know, as you can see from this table, it's more or less effective. Of course, things like migraine with aura, perhaps pituitary tumors and visual fields, and those are things that can be done or looked at remotely, I suppose. But if you look down at some of the things that it can be not very helpful in optic atrophy and other things where you can't really see the fundus via telehealth. But certainly this report indicates that many, many more neuro-ophthalmologists are using telehealth than prior to the pandemic. So in summary, there have been a wide variety of neurologic conditions and neuro-ophthalmologic associated with COVID-19. Now, the question, of course, is, well, is it really due to COVID-19? People who have neuro-ophthalmologic, any of the things we've described, obviously, they can get these for other reasons and get them prior to the pandemic for a variety of other reasons. So is it just coincidence? I don't think we know the answer for absolute sure. I think some of the cases, it's fairly obvious. A young person with occipital strokes and COVID, it's related to the COVID, but we don't know for sure that all of these things are cause and effect. These are, at this point, as we're trying to sort all this data out, and I think it's going to take some years probably to sort out the data. Do we see any of these things at a higher frequency in patients with COVID than what we were seeing before the pandemic, just in patients who don't have COVID? And the answer to that, I hope, will be forthcoming in the future. So I thank you for your attention, and hopefully you are enjoying our neuro-ophthalmology webinar for the SOE meeting. Thank you, and goodbye.